Thanks to all the audience who follows our broadcast. We're live on the third day of the 2020 International Web-Based Neurosurgery Congress. Remember, we're streaming on YouTube Live too. We have the honor today of having Dr. Jorge Torres. Dr. Jorge Torres is a neurosurgeon from Hospital Universitario de la Samaritana and Hospital Universitario Mayor Mederi. He's a professor in neurosurgery from Universidad del Rosario. He completed a spine surgery fellowship at Weill Cornell Medical Center under Roger Hartle mentorship. Dr. Torres offices as co-director of the Spine Laboratory at CIEN. Today, Professor Torres is going to share with us his lecture, Minimally Invasive Surgery in the Treatment of Spinal Metastatic Disease. Welcome, Dr. Torres. Thank you for sharing your time and your experience with us. The audience is all yours.
Thank you very much. Good day to all the attendees. We're going to be talking about MIA surgery in the management of spinal metastatic disease. I currently have no disclosures. Well, metastatic spinal disease is a growing problem. Every year there's approximately 1.5 million new cancer patients in the United States, and depending on the studies, around 40 to 70% are going to develop a spinal metastatic problem in the course of the disease. And in 12 to 20% of the cases, the manifestations of this kind of problem is going to be the first symptom for which the patient is going to have to go to the hospital. And this is a problem that is very likely to increase. Nowadays, we have earlier diagnostic availability to patients. There is a better treatment of the primary disease. There are novel therapies which have had a very good impact on the treatment, especially immunotherapy and restriction point blockers. And all this leads to prolonged survival and therefore more time for a metastasis to develop. What is the presentation usually? Well, we'll have patients with spinal cord compression in around 10 to 20% of the cases. Half of those patients are going to be ambulatory on presentation, and around 15% are going to be frankly paraplegic or with a very high neurological deficit when they present to the hospital. Most of these metastases are going to be thoracic and 20% lumbar, 10% cervical. And the origin is going to vary a little bit between the series, but definitely lung, breast, liver, and prostate are probably the most representative cancers which do metastasize to the spinal column. What about the treatment paradigms? The traditional treatment paradigm for spinal disease with metastasis in mind has been conventional external beam radiation therapy. It has been so in such a way that it has defined what is a radio-resistant versus a radio-sensitive tumor. That being defined by the response to 30 grays in 10 fractions. Therefore, we have radio-sensitive tumors, which are most soft tumors, and blood tumors, like lymphomas, multiple myelomas, plasmacytomas, and others, and radio-resistant tumors, which tend to be more solid in nature, like renal, colon, small cell lung, and thyroid hepatocellular tumors. These tumors characteristically have lower than 30% response rates to conventional external beam radiation therapy. So under this paradigm, the role of surgery was quite clear. First of all, if you have a radio-resistant histology, there would be a need for a surgical resection in order to obtain the local control. So the objectives were to do a wide decompression and as big a resection as possible, hopefully in block to avoid the migration of tumor cells in the surgical field and an oncological margin. For this, the workhorses of treatment were laminectomy and spondylectomy, which were usually done from a posterior fashion, but they were also done through lumbar or thoracic anterior approaches. Radiotherapy would then be done around 1 month after surgery, and this is because of the extensive tissue trauma associated with open surgery, which would then be at risk for complications associated to the cicatrization of the surgery. So this has some limitations. It requires that the patient is in a generally good condition to be able to resist the surgery and have a good cicatrization for the surgery. The expected survival should be around more than 6 months. Therefore, the risks would be worth it. And these procedures came with pretty high complication rates, which would go around from 20 to 40%, depending on the approach and the type of surgery that was involved. In 2006, Dr. Bilski and Laufer introduced the NOMS framework as a way to guide the treatment of spinal metastasis. And it is still today the best way to try to face and organize the treatment paradigms with respect to spinal metastasis. But in the treatment, at this time, changes were coming, and the role of stereotactic body radiotherapy was envisioned and starting to have an impact on the treatment of cancer patients. So initially, radiotherapy for radiosensitive tumors was basically the norm, but radio-resistant tumors were more surgical candidates. With surgical body radiotherapy, the paradigm starting to shift towards radiotherapy. And what was found with radiotherapy? That independent of tumor histology, there was a dose-dependent response of the tumors to the radiotherapy, with single fraction high-dose radiotherapy, local control rates of 98% at 4 years, which is very good. And this is, I repeat, independent of tumor histology, even if it's radio-resistant or radiosensitive. In cases of hypofractionated therapy, which is done for patients who have previous irradiation or have moderate spinal cord compression, and we'll go into that in a while, these control rates are very, very good, 80 to 90% at 1 year. So then the recommendation came to be that stereotactic body radiotherapy was and is the first-line therapy for patients with spinal metastatic disease and moderate to low spinal cord compression, irrespective of histology. But there are problems with this. Everything has a plus side and a minus side. So what are the risks? Well, vertebral compression fractures are also one of the problems that comes directly related with the dose of radiation. And with doses above 19 grays, especially above 24 grays per dose, we're going to have vertebral compression fractures at 30 to 40% at 5 years. Fortunately, only 40% of those have been seen to be symptomatic, and half of those will actually need to be treated. But this does cause morbidity, and that compared with conventional beam external radiation therapy is quite a lot. It's 5% only for external beam radiation therapy. Esophageal toxicity is rather low and depends obviously on the site of the spinal column that it needs to be irradiated. Radiation myelopathy is probably the thing that most people fear, but it is actually quite low, 0.5 to 1%. And the precision and the adequacy of stereotactic planning nowadays is much, much better. But it's still a problem and something that you have to take into account when you're going to irradiate a tumor. And there are constraints. You should not irradiate more than 10 grays to 10% of the whole spinal cord, or a Dmax of 14 grays. And that risk of radiation myelopathy grows with previous irradiation in cases that, for example, the patient has received conventional external beam radiation therapy. So what is the problem? Well, this might have a relationship with treatment failure. 2 studies in 2007 and 2010 evaluated the propensity of treatment failures. And Cheng found that there was actually 2 places where this was most frequent in stereotactic body radiation therapy. One would be in the bone adjacent to the treatment area or the clinical tumor volume, and the epidural space adjacent to the spinal cord. And in-field failures were found in 25% of the cases, half of those inside of the epidural space, that is inside the clinical tumor volume. Lovelock in 2010 found similar results, with all the stereotactic radiation therapy failures occurring with doses below 15 grays to areas of the CTD. and a relationship of this with the Dmax of the spinal cord was found. In such things that when the planning was done, it was a tendency to have a lower amount of radiation close to the spinal cord. And this is the place where treatment failures were occurring. So there is a direct relation between the dose and response and the lack of dosage due to the risk of irradiating the spinal cord. And that has created a restriction around the doses that can be applied to the spinal cord. So what was the response for this, or the solution to this problem? Well, this is the role of separation surgery. What is the objective? The objective is to create a separation between the spinal cord and the neural structures and the tumor bed, hopefully at least 3%, 3 millimeters, sorry. And that is because there's a dose radiation fall-off of around 10% for each 10 millimeters. So the more distance you are away from the radiation field, the dose is going to fall faster. But this does not need to be a very big distance. From 3 to 6 millimeters, you can get very safe doses and high doses to the tumor, but safe doses to the spinal cord. So the objective would be to obtain a Bilski epidural spinal cord compression grade of 1B or less, which would be right over here. This initially was proposed as a posterior surgery, as you can see here, with laminectomy, sometimes pediculectomy, and a 360-degree decompression done from behind. Local control rates are very good with this strategy, above 90%, even on single or hyperfractionated body radiation therapy. So the indication for separation surgery is high or moderate grade spinal cord compression, especially in radio-resistant tumors, but since we are talking about stereotactic body radiotherapy, really there is not much of a difference. The fact is, when it is radiosensitive, the response is going to be much, much faster, so the dose may be adjusted differently. And patients with local recurrence in cases with previous conformal external beam radiation therapy, which are going to have more restrictions with respect to the local dosage that can be applied. So then, under this paradigm, what would be the current indications for surgery? Well, as we saw before, high-grade spinal cord compression, epidural spinal cord compression with radio-resistant tumor histology, instability, deformity, especially if it is progressive in nature, intractable pain or pain that cannot be adequately treated otherwise through other therapies, local recurrence, and the need for histological diagnosis. And that would be in cases that can be seen sometimes where biopsy is not an option, percutaneous biopsy. So it's kind of a different kind of indication, but it's still nonetheless very real. So what would be the role of minimally invasive surgery in these cases? Well, MIS has proven advantages in the degenerative spine group. What are those advantages? There's clearly less tissue trauma, that's the objective. There's less bleeding, less postoperative pain, shorter hospital stay, lower infection rates, and better cosmesis. So a question arises if these advantages can be translated into oncological spinal surgery. How do we accomplish this? Well, there's very different things that we do. First, we modify approaches or create new approaches to the spine, to the management of spinal disease, through mini-open approaches and full MIS approaches. We are going to use a special equipment, especially tubular or expandable retractors, such as this one, and special instrumentation, bayoneted instruments in most cases, different types of spine instruments that are going to be applied specially for spinal surgery, and image guidance, which is one of the basic and most important parts of MIS surgery. We're not going to rely on viewing and touching anatomical landmarks. We are going to view them indirectly through image guidance, be it with C-arm imaging, 3D imaging, which can be done through navigation, or CT scans or isocentric CT scanners, navigation more recently, and robotics as an adjunct more recently. What fixation options do we have? Well, we rely basically on modified instrumentations designed for MIS, The percutaneous pedicle screw is the workhorse of spinal fixation and MIS. We have two flavors, the normal MIS screws and the fenestrated MIS screws, which are very, very important in oncological surgery. These screws will permit cement augmentation of the vertebral body, giving it more strength and at the same time lowering the chances of pullout. And this is very important in oncological surgery since 40% of patients tend to have diminished or very diminished bone mineral density, making them more propense to having a hardware failure. Expandable cages, very important when doing anterior approaches. This makes it possible to do anterior reconstructions of very small openings and preserving the neural structures, and anterior plates in cases where we need anterior fixation. What approaches are being done actually for spinal cord tumors or spinal tumors, metastatic tumors? Let's start with the posterior approaches. Well, the first is the modification of the classic laminectomy, which is the mini open laminectomy. This can be done in different manners and is the most accessible first minimally invasive surgery option. You can do it with a typical Meyerdig separator that we all know, limiting the exposure only to the segments that need to be treated for laminectomy. Or this can be done in a more minimally invasive fashion with an expandable retractor. Therefore, you can have the classical approach and envisionment of the posterior spinal cord or spinal elements. The instrumentation will be done percutaneously or in this case, transfacially. This is something that's more of the surgeon's choice. And with a little bit more experience, you can also do transpedicular corpectomies and posterior vertebral resections through the same approach. In cases where there's only one-sided pathology or you need access to only one pedicle, you can do a modified Wilson approach. This can be done also with common ordinary retractors, or if you want a more minimally invasive option, you can do this with an expandable or non-expandable retractor, depending on what instrumentation you have available to you. The over-the-top laminectomy, widely discussed by Dr. Roger Hartle, is a very classic degenerative spinal disease approach, very suited to posterior decompressions, not only in degenerative disease, but also in oncologic disease. And with a little modification by moving the two, you can have direct access to the pedicle and go into the vertebral body to do either a partial corpectomy or do separation surgery. In cases where you have bilateral disease, you can do this in simultaneous with bilateral tubular retractors, or you can take out the tube and then do the other side. And this permits a much smaller incision and less tissue trauma. The lateral extracavitary approach is an expanded approach where you're not only doing laminectomy, pediculectomy, but you do a costotransversectomy. And this gives you an anterolateral approach to the whole vertebral body and 270 degrees of the neural sac. Through this approach, you not only can you decompress the spinal cord, but you can also have enough space to put in a cage, an expandable cage, to do vertebral body reconstruction. And therefore, you can do much bigger surgery with a very small approach. For this, it is recommended to use an expandable retractor so that you can have more field of view. And you get this type of view. You have a very nice view of all the upper, lateral, and part of the inferior spinal cord. You do have to ligate one or two roots to get access for the expandable retractor, although this is variable depending on the size of the interior defect. And it has been described by doing complete vertebrectomies, or you can do half of the vertebral body in cases where the compromise of the vertebral body is not so big. With respect to lateral approaches, we have one of the most oldest or most done approaches anteriorly was the thoracoscopic approach. You need 4 incisions for this approach, one for the camera port, one for the suction irrigation port, one for the retractor for the lung, and finally one that's going to be the working port. And this port is very important, that it has to be adequately located above the pathology. You're going to have an anterior to posterior view, and this gives you a very, very good view of the location of the metastasis, permitting the full resection of the vertebral body and all the associated tissues and wide decompression of the spinal cord. One of the problems with this approach that is usually not mentioned is that you are exposing the whole of the pleural cavity. So there is the possibility of cellular or tumor cell migration into the rest of the pleural space. But this is, it has shown very good responses with respect to morbidity. It does have a steep learning curve. The mini open retropleural approach that has been pushed in a great manner by Dr. Uribe. It starts with a small centered incision over the pathology, around 5 to 7 centimeters. You remove the overlying rib, and then either with peanut dissectors or initially with a finger dissection, you divide and you separate the parietal pleura from the internal thoracic fascia. And you're actually outside of the pleural space, so there's no need for one-sided intubation, there is no need for chest tubes in the post-op. Once you do this, you put in a MIS retractable expander, retractor, and you have a direct lateral view of the tumor and the spinal cord and the spine. Once you do this, you can do a resection of the tumor. You can see here, this is anterior, this is posterior, this is caudal, this is cephalad. So here you're dissecting the tumor piecemeal. You have very good access. There's low bleeding. You can see the spinal cord decompressed right here. This is part of the most inferior decompression. This is the resection cavity, which is pretty good. You can see the pleura on the other side. You can do a complete resection of the vertebral body in a quite safe manner. And this allows you to put in big expandable retractors. This is a thoracic approach, but as you can see, we're inserting a lumbar size expandable cage. So you can have a bigger footprint to support the defect and try to lower the subsidence, the possibility of subsidence, spinal subsidence. So this is what you obtain after surgery. Then you put in a plate. It is true that due to the nature of metastatic disease, sometimes the bone quality, or you might have more tumor in the adjacent vertebral bodies. So what we have done in some cases is we do this approach for decompression, and in a second operation, we can do percutaneous pedicle screws in cases that we think that there might be more risk for losing correction or risk for kyphosis. With respect to the lateral lumbar approaches, there's two options: the transpsoas, or commonly known as axillary approach, which can be done through direct incision or an indirect incision on the lateral side, usually through the left side. Then a digital dissection of the retropleural space is done until you find the psoas muscle. Then using electromyography guidance, you're going to cross the psoas and center yourself on the vertebral body. And this is a difference. Usually on axillary, you're going to center yourself on the vertebral disc. This is going to be more centered on the center of the body of interest. And once you do that, and you have to place it in front of the lumbar plexus to avoid neurological injury, then you can put in your retractor and initiate the resection. And this can be complemented with a lateral plate, or you can do in one time, the same time, in the single position, you can put in pedicle screws. And that, depending on the choice of the surgeon, you can then do it in the same position or put the patient upside in a normal down-looking position and put in the screws from up down. In the anterior to psoas approach, you do a more anterior incision across the muscles, and then you're going to do a dissection of the retrocranial space, going all the way up to the anterior vertebral body or the anterior part of the psoas muscle. Then you're going to put a retractor to maintain the peritoneum out of the way, and you can actually retract the psoas muscle back. So you are avoiding retraction or direct retraction of the muscle fibers of the psoas muscle inside the muscle. Therefore, the risk of neural injury is less, but there is a little bit more risk to the pleural structures. You put in your retractor, and then you have free access to the vertebral body to do the retraction and the tumor resection, and then you can complement this with lateral, anterolateral, or posterior instrumentation. One of the most recent approaches, and as Dr. Bilski also talked to us in his talk, is that there is a growing interest for endoscopic spinal surgery to start managing tumors, and the endoscopic foraminotomy approach has been described to decompress the nerve roots in the spine, in the lumbar spinal column, to treat tumor-associated pain. And it has been, in its initial reports, effective. It is still too early to see how this technology is going to evolve. But this reminds us that these technologies are constantly evolving, and there is still yet to be seen what the future is going to bring to us with respect to new approaches and new technologies. So what has the evidence seen with respect to MIS when you compare it to open surgery? This study done in 2015 compared 23 mini-open laminectomies with percutaneous pedicle screws, which would be the first surgery you would do, and 19 open laminectomies with open screws in patients with rather low KPS. So what he found, there was less blood loss, lower chance of transfusion, lower length of stay, less time in bed rest for these patients done with MIS surgery. There were similar operating times, and there were no perioperative complications. But this is still rather a small group of patients. But with this in 2015, they were already thinking the results for them were so impressive that they recommended that MIS techniques should be the first choice of treatment for spinal metastatic patients with myelopathy. A second study done by Hansen Agelstedt in 2017 compared 30 MIS patients with 30 open patients. And this study combined some patients with laminectomies and some anterior reconstruction surgeries done through a thoracoscopic approach in the case of thoracic disease, or XLIF approach done for lumbar disease. What did they find? Well, blood loss was halved, blood transfusions were almost halved, the volume of blood that needed to be transfused was less, the overall length of stay was shorter. Curiously, initial VAS was higher, but at 3 months it was lower. Infection rates were 0% with MIS versus open surgery, but fluoroscopy times were higher. And this is something that has already been commonly seen in all MIS surgery, even in degenerative spine. There were no differences in operative time and number of anterior reconstructions, surgical complications, overall complications, and ICU stay. So in 2018, a meta-analysis was done by Victor Liu with studies prior to 2017. Out of 445 articles, only 6 were included due to their inclusion criteria, with a pool of 292 patients, 155 of which were done through MIS approaches and 137 through open surgery. What did they find? Well, overall, there was less blood loss with a median of 676 cc's for MIS versus 1,000 for the open surgery. There was a lower transfusion rate with an odds ratio of 0.22 in favor of MIS. There was no big significant difference in operation duration between the two groups, but a tendency towards favoring MIS surgery. There was a shorter length of stay with a mean of 4.6 days less stay in MIS cases. Lower likelihood of complications with an odds ratio of 0.41, with an overall incidence of 14% for MIS and 20% for open surgery, which is very well within the reports of most of the literature. Wound infections were only 1% for MIS and 4% for open surgery, and dural tears were more in MIS, and this is something that has also been seen in traditional degenerative spine publications. But this is something as well that is directly related with the experience of the surgeon and tends to go down with the more experience the surgeon has. There was no big difference in pain recovery, and there was no difference in spinal cord function after surgery. This is very important because some may argue that the degree of decompression that can be done with the tube is not going to be the same when you do an open surgery. And this is just not true. You can obtain very good visualization of the neural elements and a very good decompression, even though you are using a small retractor. You can move this small retractor and work in a keyhole fashion to obtain very big views and very big decompressions through a very small opening. And this is something that is supported by the study and most other studies. What about MIS corpectomies? This is a much bigger surgery. So last year, Spiesberger did a study, a revision of the literature, a review. 857 articles, 63 were selected, 774 pooled patients, an average age of 51 years, and a follow-up of 1.5 years, with a mean of 1.5 levels treated. What did he find? Well, first, they took 7 groups of patients, envisioning 7 different approaches to corpectomy. The en-bloc spondylectomy, the transpedicular, the costotransversectomy, the mini-open retropleural or retroperitoneum, the lateral extracavitary, the open transthoracic, and the thoracoscopic. All of these were open except the mini-open and thoracoscopic groups. And he started in them, they did a comparison. So what was found? There was lower blood loss, as you can see right here, both in the mini-open and the thoracoscopic group, especially when related to the en-bloc and vertebrectomy. Operating times were lower in the mini-open and retropleural approaches. Even the thoracoscopic approaches had a tendency to have the same or lower time in spite of the technology used. There were lower complications with respect, especially in this the mini-open procedure. And there were similar improvements in axial pain. One of the curiosities with respect to pain was that the mini-open group had a tendency to have initial higher pain. And they related this to the lateral fixation, that they thought that maybe the lateral plate was not as biomechanically stable as the pedicle screw construct. But what we have been seeing in our experience is actually that these patients have much less pain than lateral posterior approach patients. So what is the role of MIS in the treatment of spinal metastasis? Well, there are proven benefits, as we saw in degenerative spinal disease. There's less blood loss, there's lower transfusion risk, and when you do have to transfuse, the patient will need a lower blood volume. There are lower complication rates, lower infections, there's a lower length of stay, and there's better prosthesis. Remember that MIS does not mean small incision. You can have many incisions, or you can have sometimes even a larger incision, but the muscle, facial, vascular, and neural trauma is lower. That's the important part of the surgery. Comparatively to open surgery, it is the same with respect to decompression, fixation, operation time, and this improves with the experience of the surgeon, post-operative pain, and spinal cord function. There are some other additional benefits to MIS. First, there's a shorter time to restarting radiotherapy treatment, and this is because of the small approach. So radiotherapy can be planned around the approach, therefore not compromising the healing of the approach. So traditionally through MIS surgery, you can start stereotactic body radiotherapy 1 week after surgery. And sometimes, if with adequate planning and communication, you can do this the day after surgery. Whereas in open surgery, you usually have to wait at least a month. And this can be done safely in more compromised patients. So under this type of surgery, patients that were not candidates for open surgery because of their general state, then these patients might be candidates for MIS procedures, and therefore we can give them an alternative other than just radiotherapy. So with this, I would consider that MIS surgery with stereotactic body radiotherapy is becoming progressively more and more the new paradigm in treatment of spinal metastasis. But there are drawbacks and there are barriers to this. First of all, there is an accessibility barrier. You do need special equipment that is not available everywhere, and you need training. Not only training for the spinal surgeon going into these approaches, but you also need training of your OR staff to know how the different steps of the procedure should be done in an effective manner, and the radiology technicians. It doesn't matter if you're doing an O-arm surgery or a CT surgery or a simple C-arm surgery. You are going to need a technician that knows what you're doing and what you're going to do. There are a multiplicity of techniques, as we saw previously. This requires a training curve that's going to start from the smaller procedures and progressively grow into the bigger procedures so that you can maintain safety. And there is a lack of prospective studies in this respect. As you saw in the meta-analysis, although there was a large amount of studies, most of these were case reports or 3 or 4 patients reports. We need larger studies to see the whole impact of MIS surgery. With respect to newer techniques, there are very few studies, especially when it comes to new techniques for corpectomies, for MREs retropleural with corpectomies, the lateral extracavitary approach through MIS, OLIF and XLIF for corpectomy. Usually it's just case reports. And endoscopic decompression, which is something that's just barely starting to come into play. So one of the big questions, and this is quite clear when it comes to first world countries or countries and places where you have access to stereotactic body radiotherapy. Remember this is a very complex equipment. It has a big cost, not only a cost to obtain the equipment, but also to use it. So it is expensive. And most developing countries do not have access or easy or ready access to stereotactic body radiotherapy. So in many places of the world, the first paradigm of open surgery and conventional external beam radiotherapy is still in work. And there are no studies yet trying to evaluate what is the impact or what would be the role of MIS procedures in the context of conventional external beam radiation therapy, and what the results would be in the medium and long term of these kinds of treatments, because they are not the gold standard of treatment, but unfortunately in many developing countries this is not possible. So this is something that I think has to be studied further, and for all those surgeons in different parts of the world, in developing countries like mine, this is not something that should take you away from MIS surgery. On the contrary, it should give you more reasons to try to invest your time in research in MIS surgery, because if there are benefits with radiotherapy, there are going to be benefits with conventional therapies. And with the evolution of the techniques, you are able to do bigger decompressions in cases where it's needed, still retaining the benefits of MIS techniques. And well, I think this is all for today, so thank you. I'd like to thank all the attendees to the IWBNC, in part of my colleagues at the CIEN, and I am open for questions. These are our hospitals, And this is our work group with residents and neurosurgical colleagues. You are welcome to come in contact and visit us.
Well, thank you very much. Thank you very much, Dr. Torres. It has been an splendid lecture, and I'm sure all the attendees have learned a lot from your experience and the images that you just showed. Right now, we have questions, and I'm going to go ahead and read them to you. The first question says, where would you use lateral spinal plate and where not use it?
That's a very, very interesting question. The first question, I think, related to that would be when you would have to do an anterior approach. That is obviously something that you have to tailor to each case. But usually it's in cases where the vertebral body is collapsed and you have anterior compression, and you have to do the decompression, but at the same time correct some kind of kyphosis. Since these patients have low bone quality, it is not a very good idea to come in from the back and apply huge corrective forces. This is just the recipe for a pullout. So in these cases, sometimes it's better to come in from the front and do a complete or partial resection with decompression of the spinal sac. And then you use expandable cage and put in a plate. So through, for example, a mini open retropleural approach, which is what we usually tend to do. This is very simple. You can put in very big plates through a very small opening. But sometimes you will find that there's maybe not a very good bone for purchase of the screws of the plate, and this is a problem. So in these cases, you would have to make a decision. If you can do this with the CT scan previously, it's better. If not, you should be prepared for this in surgery. That is to stop there and immediately do a posterior transpedicular fixation, which can be done in the same position. Or if you planned this previously, you can put in the plate and then in the second time or in the same surgery, do the posterior fixation.
Okay, sir, thank you. What is the incidence in minimally invasive surgery related to injury of surrounding neurovascular structures in comparison to open surgery?
Well, there's the risk depends on the approach. So it's different, for example, for an X-lift, for a no-lift, or a thoracoscopic approach. And so it's very variable. It's actually quite low. With open surgery, it's basically very much the same with respect to the anterior approaches. With respect to the posterior approaches, the incidence is low if you come into the big vessels. For the segmental vessels, it's quite common. You actually look for them and try to coagulate them early in the procedure in order to minimize blood loss and diminish the irrigation to the tumor. But you do have to always take into account the spinal irrigation. So when you look at the MRI, do take a look at the size of the segmental vessels. It's going to be variable, and if you have a dominant vessel, try to preserve that in order to avoid spinal cord injury. Also, if you're doing an MIS, it's not such a problem. In open surgery, if you're doing a bilateral approach for spondylectomy, for example, you do try not to do more than 2 levels sacrifice of the segmentals because you're putting the spinal cord at risk. With MIS, this is usually not a problem because you're coming in from one side or lateral, so you're only sacrificing the vascularization from one side. So it's much, much less of a problem.
Okay, sir, thank you. Regarding COVID, any special tips for thoracoscopy and retropleural approach in the COVID area?
Well, I don't do much thoracoscopy, it's quite infrequent. But for example, the mini open retropleural, the thing is you're not in the pleural space, or you're not really coming into contact with respiratory secretions. do not need unilateral intubation. So I would think there would not be very special considerations. You do have to take into account that you do need to use the proper PPEs irrespective of the case. There are going to be micro vapors produced through the drill, through the monopolar. So I would say the risk is quite the same. Compared to open approaches, it would be much less. Everything is going to channelize through the tube and going into the suction if you're doing a tubular retractor case. And in the case of a mini open, it's about 5 to 7 centimeters incision. So it is, I would think the risk is lower, but there's no studies on that. Would probably be just my opinion.
Okay, sir, thank you. There's a question here that says, have you had to convert to open procedures? And if yes, why?
That's a great question. I think maybe I've been lucky. I have not had to do that. But you always have to be prepared. Irrespective of what approach you do, even the initial most simple case, which would be a mini open laminectomy with pedicle screws, you have to drape in preparation to conversion to open surgery. And that's something that I still do. I've been doing MAS for more than 10 years now. And in every single case, I always wash and drape in case I have to do a conversion. I think the key to avoid conversions to open surgery is surgical planning. For MIS, I think for every surgery, any kind of cranial or spine surgery you do, the adequate patient selection, technique selection is the key to avoiding complications. So if you have selected the case adequately, have done adequate pre-op planning, use the adequate imaging from CT scan, MRI, do take into account bone quality in your planning, then you might not have to convert. Why do I say about the bone quality? Well, in patients with diminished bone quality, well, the quality of imaging that you're going to be able to obtain through a normal C-arm is going to be much lower. So as we saw, 70% of thoracic cases. And if you cannot see the pedicle, then you cannot cannulate the pedicle. So in cases where the visibility on an X-ray, you do an AP spine X-ray or a PA spine X-ray, and you cannot see the spine pedicles, I don't think that would be a good case for C-arm MIS because you are just not going to be able to see the pedicles. For these cases, that's, I guess, where is the role of intraoperative imaging and the style of CT or O-arm, and spinal navigation would be ideal for these kinds of cases where traditional C-arm are not adequate. One of the other situations where maybe more complex imaging is required is in the upper thoracic spinal column, since there's also some visibility problems with conventional C-arm radiology.
Okay, sir, thank you. Somebody's asking, Kalowski, what about bone fusion with MIS procedures? Our patients live longer, so there is bigger chance of implant failure and lack of fusion. How do you deal with it?
That's a very, very good question. It depends on what you're planning. In all the studies that you review with respect to MIS and spinal metastasis, the big problem is follow-up. It is very rare to see follow-ups going beyond 2, maybe 3 years. And the problem is that above the 1.5 year mark, you tend to have follow-up of patients due to morbidity or mortality associated to the primary disease. So one of the things that's clear within the role of spinal surgery today with respect to spinal metastasis is that our role is palliative. We are not treating metastasis with MIS surgery or open surgery of the spine. We are doing a palliation surgery to treat deformity, pain, preserving spinal cord function. So for many in this context, fusion is not always as important, but you do have opportunities for fusion. When you do the posterior cases, you can put in bone graft. Usually we tend to use a bank graft, or you can use DBX or any kind of these types of grafts. Some people tend to use ceramics. I don't prefer them so much for this kind of cases. They do tend to produce more secretions, and they do not, tend to just stay there and not create fusion. When you do any kind of anterior construction, that's the perfect opportunity for fusion. And one of the things that we tend to see is that after, if you do not do a oncologic resection, which is mostly the case nowadays, where you will do a decompression, once you do radiotherapy to the lesion, bone quality improves. So then the fusion is not that important. What does the report say with respect to failure of the screws? With respect to MIS screws, the failure rate or pull-out rates is surprisingly low. I think that maybe it should be a little bit higher, but it's reported around 2.8%, which is very, very low. I think maybe that's a lack of studies. But in favor of that, if you think that there's a high risk for failure, then you would use cannulated screws and do body augmentation. And one of the other things that's important to take into account is that you can also do augmentation of the involved level. So if you do a partial resection, you can also do vertebral augmentation or vertebral plastering to the involved segment, therefore diminishing the actual load on the construct. And that also helps to diminish the need for fusion and diminish the possibility of screw failure.
Okay, thank you. There's a question outside METS, but I think it's interesting, and it's about fusion. Outside of spinal METS, do you consider percutaneous instrumentation in patients with ankylosing spondylitis a viable option, or are you concerned about the fusion?
That's a very good question. One thing that I wanted to annotate with respect to the previous question, the one thing you should not do is use BMP. Remember, a BMP is a trophic factor, so it's anabolic, and therefore it is contraindicated in any kind of tumor case. With respect to ankylosing spondylitis, well, that's a very complex disease. Maybe MIS fixations are not the very best way to go. You do need solid fusion, and for that you're going to need a lot of bone graft. But in many cases, you do have, for example, a spinal cord compression or radicular compression due to spinal stenosis. And for these cases, MIS is perfectly suited. You would not and cannot expect indirect decompression in these kinds of patients. Remember that all the ligamentous structures are going to be fused or very hard and thickened. So there is no way that you're going to get a big implant to create indirect decompression, for example, in the case of lateral with be it transpsoas or antipsoas. So that is not the indication. But I think you would have to actually see each case and see what applications are available for that. Once you get into doing MIS, you start to see what kind of surgeries are more amenable to it. So you would have to do it on an on-case basis. But for example, a traumatic fracture, which can happen with very small traumas, these kind of surgeries would probably be better addressed through an open approach than through MIS approaches.
Okay, thank you. Thank you very much, sir. In your experience, in cases in which you have instrumented after spinal canal decompression and pseudoarthrosis arises due to advanced oncologic disease, what would be the best approach or strategy to surgically treat these patients?
That's a good one. Complex. It depends on the degree of pseudoarthrosis. If there's a big the hole where the screw was, then the posterior fixation has to be removed. And then the alternative would be, depending on what how much vertebral body is left. You can do another approach. You can do a cortical pedicle screw approach if you have that available. If you have navigation, you're going to have much more options because you can plan different trajectories. And depending on the disease and the state of things at that moment, you can even plan for an anterior intersomatic fusion. For example, for a lateral lift, O-lift or X-lift approach. So it's something that you would have to plan depending on the problem. Sometimes you might have an MIS option. Sometimes then you just might have to do an open surgery so you can have interlaminar or intertransverse fusion. So it would depend on the degree of pseudoarthrosis, the type of pseudoarthrosis that you're treating, what the solution might be.
Okay, sir. Before we go on with a couple more questions, I'm going to go ahead and tell the public that Dr. Michael Levy's presentation is about to start at 1400 standard daytime. You can go ahead and log to that conference using the chat or by going back to the web page and clicking on Join Now. And it will be the last conference of this first International Web-Based Neurosurgery Congress. So I'm going to go and read a couple more questions for you, sir. In your experience, sir, with the NOMS framework, have you seen great or little utility in determining the patient's oncological and neurological prognosis?
That's a very, very good question. The NOMS framework is a way of thinking. But when it comes to treating spinal metastasis, and I would say all oncologic disease, it cannot be a one-headed adventure. You need a team. You need, hopefully you're in close contacts with your oncology colleagues. Sometimes we're with your internists that are going to be attentive to all the medical complaints of your patient, to nutritionists, to the physical therapy, even to this, to the social support, because it's not the same a patient that has very good social support at home, family support, to one that's, for example, institutionalized in a care center. So the decision, and one of the good things of the NOMS framework is that it makes it flexible to take account different aspects of the patient so that you can make a tailor-made approach to the treatment of a specific metastasis. It's not, you may have the same histology and the same vertebra with the same problems, but manage it completely different depending on the specific characteristics of that patient and also of the treatment options that you might have available. If you have stereotactic radiosurgery, then maybe you can go for that. If you do not have that, maybe you might have to go for a more a surgery for control before he gets radiotherapy, or maybe he gets stereotactic therapy, but maybe who knows, months after that. Things are very complex when it comes to the healthcare networks of different countries. So I think that one of the biggest advances in the treatment of spinal metastasis is this framework, and it's growing every day. You're doing more indices, you're using more scales, and you have to use these, and you have to try to add to this your experience and the social conditions of your country and your healthcare network.
Okay, sir. I think I'm gonna ask the last question. Here we have, what is your opinion about the role of biopsy in spinal metastatic disease from unknown primary to guide the treatment in a patient with spinal cord compression? Do you consider wait to the results to determine if the tumor is radiosensitive, or do you prefer to operate?
That's a great question. Dr. Bilski on his talk earlier touched some aspects of the question. It depends. I think that the answer, it depends. It depends on what? On your resources and the needs of the patient. Definitely, if you have a cyber knife, for example, or any kind of stereotactic body radiation therapy in-house, histology is not that important. Remember that the response to stereotactic body radiotherapy is irrespective of histology. So if you have a patient that needs treatment, you do not need to have histology to do the radiotherapy. But in most places, that's just not true. And then you do need very much so to know if it's radio resistant or not. So in those cases, a biopsy is preparatory. You might have to do the biopsy. And depending on what alternative or what access to radiotherapy or what kind of radiotherapy is available, and if the patient has neurologic symptoms or deformity, then you're going to plan the extent of your surgery. You can do a simple mini open biopsy, a percutaneous biopsy, or maybe you're going to have to do separation surgery. It would depend on the specifics of each patient. But when it is ideal to have histology. Obviously, before you think of surgery, you're going to have to do exams, CT scan, mammogram, markers, serum markers, to see if you can find the primary tumor. Once you do that, then your treatment's already going to be guided. But for our oncology colleagues, it is very important to have an idea of the primary source, especially take into consideration that nowadays it's not just important to say, oh, it's a melanoma. It's what kind of melanoma. What are the tumor markers depending on the histology? Because with the development of tailor-made treatments to different origins or cancers, the oncological treatment is going to vary. So with respect to only the spinal metastasis, it may not be such important. If you have stereotactic body radiotherapy available, but with respect to the treatment of the patient, which is important, then you do need histology so that the oncology colleague can guide treatment. So I do think that the biopsy is important. How you're going to obtain the tissue, that's going to vary depending on the objectives of treatment and what kind of radiotherapy you have available and what time to radiotherapy you have available. It's not the same thing if you can have stereotactic body radiotherapy today, tomorrow, in a week, in a month, or maybe never. You're going to have conventional external beam radiation therapy. And even for that, in some places, you do not have immediate availability of this kind of treatment. So all that has to be put into consideration. So then the biopsy, sometimes it's going to be a biopsy, sometimes it's going to be a bigger surgery.
Okay, sir. Well, I'd like to thank you on behalf of CN for your time, your participation, your presentation, your experience has been incredible. It has been a wonderful lecture. More than 250 people were connected, and you know that more than 3,200 have been with us during these 3 days. Right now, Dr. Levy's intervention is starting on the other channel, so you can log in using the chat or the web page. Thank you very much, Dr. Torres, for your intervention again, and hope to see you soon.
Thank you very much.